This lecture will cover mobile radiography. Mobile examinations are any exams that are performed with the mobile equipment outside of the X-ray department, for example, in the operating room, emergency room, or inpatient rooms. They are an ultimate test of the skill and ability of the student or radiographer. There are many variables to consider when performing mobile radiography: room size and setup for the equipment, patient ability, the required radiographic position, exam accessories such as positioning aids and markers, high-stress environments like sterile fields, trauma, and life-saving strategies, and additional critical equipment such as IV poles, monitors, and crash carts. Communication is crucial not only for the patient that's having the exam done, but also for support staff and family members. Prior to entering the room with mobile equipment, you should enter the room yourself and identify yourself, what department you are from and what you're going to do, how you are going to do it, and what you need from the patient, family, or staff. Provide adequate information about the exam so that the patient can make a decision with informed consent. Move any obstacles that may interfere with the exam and before bringing the machine into the room. And then after setting up the machine, announce in a loud, clear voice that an X-ray is being taken so that anyone in the area has the chance to get to a safe distance from the source. Portable X-ray machines and accessories are big and bulky. Be careful when manipulating the equipment in sterile fields, near critical equipment, near patient IV, catheter, or monitor lines, and around patients' beds, family members, and staff members. Patients are almost always unable to assume the routine position during mobile exams. The patient's beds are not made to sit at a 90-degree angle. Trauma patients may require the exam to be altered due to pain, injury, and ability. You should always attempt to perform the mobile exam as closely to routine as possible. Air fluid levels are required to properly demonstrate sinus, chest, and abdomen anatomy and pathology. If patients are unable to be positioned completely upright, a semi-erect position would be better than supine. Review the coconut drawings in the text for examples of this. Here are some examples of abdominal air fluid levels. Here's an example of a sinus air fluid level. And here are some examples of a chest air fluid level. The walls of an X-ray room are lined with lead to absorb the primary beam prior to reaching the areas surrounding the department. The walls in the operating room, emergency room, and patient rooms are not designed for radiation protection. It is important to educate patients, staff, and visitors about radiation protection and where the best location for them would be during the time of the exposure. The 72-inch cord on the portable machine allows for the student or technologist to take the exposure from a safe distance from the source. Mobile equipment can come in various sizes, designs, and capabilities. Portable units are hand-carried. Mobile units are driven or pushed. Typically, the term portable is used generically for all mobile exams. Here are some images of some portable X-ray equipment. There are many technique selection considerations when performing mobile or portable exams. For KVP, the mobile units produce similar energies to stationary equipment. Mass. The older units were not able to utilize higher mass settings, but the new units have been improved but still have some limitations. SID. Measuring devices are built into each mobile unit, and it is crucial to measure SID to determine appropriate mass settings. Grids. Proper tube, IR, and grid alignment is difficult. The primary beam must still be perpendicular to the IR and grid to achieve an optical image. Remember, portable mobile machines run on battery power. They are not connected to the power in the circuitry system unless charging. In order to take an image which requires high KVP or high mass settings, the unit must be fully charged. In summary, patients who are unable to come to the radiography department can still have exams done. Students and technologists must ensure safe operation of the mobile equipment. Take the time to explain, describe, and clarify what is being done and why. And take the time to ensure that radiation safety measures are practiced when possible during mobile exams. This lecture will cover tomography and digital tomosynthesis. Tomography uses motion to show anatomical structures within a plane while blurring the detail of structures above and below that plane. It was developed in 1921 and is a precursor to computerized tomography, or CT. It is still used today to visualize the TMJ joints, urinary system, and an advanced theory for mammography. Some synonyms of tomography include planigraphy, stratigraphy, and laminography, and body section imaging. Principles of tomography include synchronous movement of two of the three elements in the tomographic system, which include the tube, the object, and the image receptor. The tube and image receptor move simultaneously in opposite directions around a fulcrum point. Motion in a radiographic image creates blurring, which causes a loss of detail. The objects in the focal plane, or at the level of the fulcrum point, remain still and clear, while the objects above and below that point are blurred. The blurring removes the superimposed anatomical structures so that the pertinent anatomy can be visualized. The greater the distance from the fulcrum, the greater the blurring. The tomographic angle, also known as tomographic arc, is the total tube travel distance. It is always greater than or equal to the exposure amplitude. There's an inverse relationship between tomographic angle and slice thickness. Exposure amplitude, also known as the exposure arc or angle, is the total distance the tube travels during the exposure time. The exposure angle is always equal to or less than the tomographic angle. Blur is the streaking or smearing of objects above and below the focal plane. It is affected by exposure amplitude, the distance from the fulcrum, the distance from the image receptor, and the orientation of tube motion. Phantoms are blur edges which do not correspond to real structures. These are false images created by complex tube motion. The fulcrum is a pivot point that the tube and image receptor are moving around. This determines the focal plane and controls the section level. A fixed fulcrum means that the patient is moved up or down around a fixed point. A variable fulcrum means that it is adjusted around the area of interest. The focal plane is the area of interest. Synonyms of this include the section level, layer height, object plane, section, and depth of focus. It's not an exact science, and objects near the focal plane are the least blurred. Section thickness is the width of the focal plane and is controlled by the exposure angle. There's an inverse relationship between the exposure angle and section thickness. As exposure angle increases, the section thickness decreases, and vice versa. The section interval is the distance between fulcrum levels. It should not exceed the section thickness. Typically, 3 to 5 tomographic images are taken to completely image an area of interest. These images have a specific section interval between them. For an example, for an intravenous pyelogram, 3 to 5 tomograms may be taken of the kidney area. You will measure the patient and divide by 3. That is the starting image. The next 2 images are typically 0.5 inches from the starting point. There are various types of tube motion. Linear means the tube moves in a linear fashion from left to right. Curvilinear means that the tube moves in an arced fashion from left to right. The more complex the tube movement, the greater the blur. Curvilinear is preferred because the SID and OID are maintained throughout the tube movement. Linear is still the most common due to cost and its ability to be attached to any X-ray unit as needed. Digital tomosynthesis is based on tomographic principles. Approximately 10 exposures are taken to establish an adequate image base. This is very similar to computerized tomography, and this is typically used in breast imaging. Section levels can be thin sections of anatomy rather than complete structures, for example, the kidneys versus the abdomen, or the TMJ joint versus the mandible. Superimposed structures are blurred to provide better detail to the anatomy lying deep within the body. This shows an example of the difference between IVP tomography image and static images. With tomography, the exposure time is need to be longer to allow for blurring. The length of exposure must match the length of time required for the tube to complete the exposure amplitude. Low MA stations are required in order to obtain longer exposure times while maintaining density. All fine technique adjustments are made by using KVP because of the limits to changing MA and time. Some specialized uses of tomography include zonography, which is also known as narrow angle, and used when exact location of area of interest is unknown for localization purposes. Wide angle is used to gather more detail about the area of interest after it has been localized. And panoramic can be used to image curved objects such as the mandible and the head. In summary, many physicians believe tomography is obsolete, but IVP and TMJ exams are still quite common today.